Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank the following Keystone funding partners for their ongoing contributions that support all of our programs and activities: the Stollery Children's Hospital Foundation, BC Children's Hospital Foundation, the Children's Hospital at London Health Sciences Centre, the Alberta Children's Hospital Foundation, the Children's Hospital of Eastern Ontario, and Holland Bloorview Kids Rehabilitation Hospital. We would also like to thank the organizations that provide funding for our knowledge translation activities, which includes this Spark Live webinar series, the Spark Conversations blog, and the Knowledge Exchange Network. To learn more about Children's Healthcare Canada, you can go to our website, follow us on Twitter or Facebook, or you can sign up for our weekly Spark newsletter at childrenshealthcarecanada.ca/email, where you will learn about upcoming events, read the latest posts from our blog, and other exciting news and events from across the child and youth healthcare community.
Hello everyone, and welcome to Children's Healthcare Canada's Spark Live webinar series. I'm Paula Robeson, your host for the next hour. Spark Live is where we gather each Wednesday to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community, with our goal to spark conversation, ideas, and action. Since we are live, I want to remind you that we don't take questions over the line, but you all have an opportunity to type your questions into the question box at any time. I'll check frequently for questions throughout the session, and so please don't feel you need to wait till the end of the presentation before you start typing your questions. Go ahead and put them in as you think of them. Today, we're partnering with Solutions for Kids in Pain, or SKIP, to bring you Partnering for Pain Top 10 Priorities. As many of you know, SKIP is a knowledge mobilization network, one of Canada's networks of centres of excellence, working to bridge the gap between existing evidence-based solutions and patient care. SKIP is co-led by Dr. Christine Chambers at Dalhousie University and Doug Maynard, Associate Director here at Children's Healthcare Canada. SKIP was created to address the knowledge gap, the knowledge to practice gap, often up to 17 years, from the time research is published to the time it has an impact in clinical practice and benefits children and families. We're building on Dr. Chambers' work with the It Doesn't Have to Hurt initiative that connected researchers and the latest evidence in pediatric pain with patients, families, clinicians, leveraging media partners and others to be creative in how we mobilize knowledge. Now on to the webinar. 3 years ago, Partnering for Pain was established. This national patient engagement project sought to co-produce the future of pediatric chronic pain research and care through partnership with patients, families, researchers, healthcare providers, and advocacy groups. A key outcome of this was the completion of a rigorous priority setting partnership to identify the top priorities for research and care in pediatric chronic pain in Canada. I'm delighted to welcome our speakers today. Dr. Katie Burney is a registered psychologist in the Vi Riddell Children's Pain and Rehabilitation Service at Alberta Children's Hospital. And Katie is also the Assistant Scientific Director of SKIP. Katie is joined today by Catherine Dibb. Catherine's a neuroscience student at Dalhousie University, and she's lived with chronic pain for over 7 years and dedicates her time to helping others with chronic pain. For those of you on Twitter, please add @ChildHealthCan and @KidsInPain to any webinar-related tweets. And as well, you may also wish to include the hashtag Partnering for Pain. It's my pleasure to pass the mic to Katie.
Hi, Paula. Thanks so much for that kind introduction. As you'll see, as we talk about our Partnering for Pain project, I'm really thrilled to be co-presenting with Catherine, who's one of our patient partners. And we're doing as we do in our Partnering for Pain project and collaborating virtually ourselves. So I'm in Calgary and Catherine's in Halifax today. So I'll just let her briefly introduce herself too.
So hi, everyone. As Paula said, I've had chronic pain for 7 years. It started when I was 16. And I actually got involved with the project because I was a mentor with the Comfortability Initiative here at the IWK in Halifax. And the psychologist, who is Dr. Jill Chorney, put me in contact with Dr. Burney to partner on this research project. And it has been such a great experience, and we're excited to share it with you.
Awesome. So I'm going to give a bit of background information about the project and what we did and where we landed. And then Catherine's going to talk about her experience as a patient partner and just provide some examples and tips and reflections on those activities. And we look forward to any of your questions and discussions, and we'll try to take some time throughout to pause and see as we go. So one of the things that I think is really important as we look at patient engagement, and particularly in the area of pediatric pain, is that the field itself was really born out of a marriage of science and public concern. And this is a quote from an article written by Dr. Pat McGraw, who is one of the, let's call him a founding father of pediatric pain, looking at a modern history of the field. And the field really came about in the late 70s, early 80s. When two things were happening. One was science was, the first studies were coming out looking at the negative impacts of poorly managed pain in newborns and young babies, coupled with a mother, Jill Lawson in the US, whose premature born son had surgery with no anesthetic, just a paralytic, so that he wasn't able to move. And of course, she thought this was appalling. And when we think about this today, we all agree, but that was standard care back in the late 70s, early 80s. And it was really this coming together of new science and research evidence, coupled with a mother's experience on a public stage, that really the field of pediatric pain was born. And I think this is where, the spirit of, I think, some of the work that we're going to present today comes from, that without science, the public outcry would not have a knowledge base. But without the public outcry, the knowledge is created, but it's not adopted and it's not used. So there's real impact when these partnerships and two perspectives come together. And since that time, the field of pediatric pain research has grown exponentially. So this was a review of all published scientific articles in pediatric pain in any scientific journal, starting from 1975. It's a bit outdated now. It goes up to 2010. But what you can see is this incredible exponential increase, which has only increased further over the last 40 or 50 years. So it really is a field where the knowledge we are gathering about to understand pain is just astronomically different than at that time. So I want to step back and just talk about what patient engagement is. Involve is an organization in the UK that is quite an international leader on public involvement or public engagement in health and health research. And they define patient engagement as research that's being carried out with or by members of the public, rather than what's traditionally done. So research being done to, about, or for them. Sometimes people hear the phrase, nothing about us without us, but it's really capturing that value and impact of engaging people with lived experience. In Canada, our engagement of patients and families in health research is driven a lot by definitions put forward by the Canadian Institute of Health Research. That's our largest health research funder. And the way they define it in patient-oriented research is that it's meaningful and active collaboration in 4 different areas. So governance, priority setting, determining what should be studied, how it should be studied, so actually conducting the research itself, and then translating, disseminating, sharing that knowledge in a meaningful way. This is a spectrum of patient engagement in health research that was actually adapted by Virginia Vandal Walker and other colleagues in Alberta, taken from the International Association of IAP2 spectrum of engagement with members of the public. And what you can see from one end is really where traditional research has sat, where patients are engaged to be, where researchers learn, teach them and inform them. They ask questions, but really researchers are the ones who are providing information and answering questions. And what we see is that there's a real need to be flexible across this spectrum of engagement, increasing the level of partnership with individuals with lived experience, moving from that traditional participation as a participant in a research study through to potentially in consultative roles and focus groups, being involved directly on the research team, being on equal footing through collaboration as equal team members with researchers, all the way up to the other end where it's people with lived experience who are leading projects, making decisions, designing things, and it's really the researcher who's in a supportive role in making those things come to fruition. And I think I present this as a spectrum as well because I think there's not one right fit for all projects or all activities or all research, but that we need to move towards this right side of the spectrum, towards greater partnership and engagement, and away from researchers driving everything and members of the public being there just to learn and be informed. So what is the evidence for engaging patients and families in child health research specifically? I will say this is a growing field and of research evidence, and this is an area where we still need more work to really show the benefits directly in an empirical way. I think those of us who engage this work see this and feel this and embody this, but I do think in terms of the research evidence, we still have a ways to go in gathering that. But what we do have shows that partnering with patients and families as members of research teams enhances the quality, appropriateness, and relevance throughout the research process. So deciding what to study, how to study it, analyzing it, and sharing it. That it leads to more effective, efficient, and meaningful research to patients and families. That it reduces this knowledge to practice gap. So it increases the likelihood that research will be taken up into clinical care. And it avoids wasting research funds and efforts in areas that are not important to people who are impacted most by this research, who are living with these health conditions every day. So several years ago, as Paula mentioned, we were successful with a CIHR patient-oriented research collaboration grant to develop Partnering for Pain. And our goal was to co-build a sustainable patient engagement strategy to guide pediatric chronic pain research and practice in Canada. And you'll see some of the other contributors and funders. We had 4 kind of priorities to our project. One was to identify the top 10 research priorities in pediatric chronic pain care in Canada, and that's where we'll focus our presentation today. And the second, which is work we still have ongoing, is to create an online Canadian patient engagement registry specifically for individuals with lived experience with pediatric chronic pain to get connected with researchers. To start curating and pulling together patient engagement training materials for patients and families, as well as clinicians and researchers, to build capacity across stakeholders to engage in this type of work. And then, of course, we really wanted to evaluate the success of our partnership to show the impact of what we were doing. And we were also very grateful to be successful with an Empower Award from the Ontario SCORE Support Unit, which was a specifically targeted knowledge translation award to further our work. This is our project team. I'll tell you, it's continued to grow over time as we expand our activities, but it started with a connection with 5 pediatric chronic pain sites. So there are 10 interdisciplinary pediatric chronic pain clinics across Canada, and 5 of those were involved in our project. When we started this, I was actually a postdoc at Sick Kids. I'm now a psychologist at Alberta Children's, but it's been a wonderful partnership across the sites. And we had a number of pediatric pain researchers from different disciplines, as well as those who are actively practicing. And we have had, 8 to 10 varying at different times, youth who have lived experience with chronic pain, and parents as equal partners on the research team throughout the project. We've had some government stakeholders, more specifically in Ontario. And then we've grown our patient and organization partners. So Pain BC, the ILC Foundation, the Chronic Pain Network, which is the CIHR SPORE network focused on chronic pain, and then SKIP, as SKIP has become a new organization in the last year. We've certainly worked to partner with them in terms of our knowledge mobilization activities. So I mentioned that, our focus today is to talk about our priority setting process. This group from the Alberta Spore Support Unit did a review a couple of years ago, looking at the different approaches to patient and public engagement in health research priority setting. And they were able to categorize them in looking across that spectrum in terms of level of patient and public engagement and researcher participation. And the role of members of the public. So whether that was more deliberative, so there's more dialogue, negotiation, more involvement and leadership of patients and parents, versus more consultative, so more where the decisions still kind of lie with the researchers, but there's more limited interaction or formal dialogue, and members of the public and patients are more consultative. What they did identify was that the James Lind Alliance Priority Setting Partnership is one of the most robust, strategic, objective, inclusive research priority setting partnerships to involve patients and families to promote equity in their voices in the process. So if you're interested in pain, we'll show you ours. If you're interested in other areas of health or child health, the JLA has a wonderful website about this process, and they have dozens of top 10s of priorities for research that are well worth looking through to see. So neurodevelopmental disorders for kids, adolescent and young adult cancer, and a number of others, preterm birth. So you may find this overlaps with several other areas of interest for you. So I could stop here, Paula. I don't know if any questions have come in, or we can keep going with our priority setting process itself. Maybe I'll pause for a moment.
No questions about the content so far. Just a good time to remind everyone to type your questions in as you have them.
Awesome, thanks. So we followed a modified James Lind Alliance priority setting process, and we did this in 4 steps. And our, as you'll hear a little bit more from Catherine, our patient and parent partners who were part of our project team across the country were part of our steering committee for this process. So working to oversee the whole process itself in partnership with us as healthcare providers and researchers on our project team as well. But at each stage of this, we engage Canadians who've had chronic pain during childhood, family members, and healthcare providers. So what's quite neat about the James Lind Alliance priority setting partnerships is that researchers are not involved in determining what the priorities for research should be. I think they get lots of opportunity. We get lots of opportunity to identify what we think is interesting. But the JLA process really puts that emphasis on people who are living with chronic pain or have had experience with chronic pain every day, those who care for them and who are closest to them in their lives, and those who are really frontline in terms of supporting them with treatments and care. So we've started off with a national survey. We had 215 Canadians from across the country participate. 40% of those respondents had their own lived experience with chronic pain during childhood. A quarter of them were family members, and this was quite a diverse group of family members. So grandparents, siblings, parents, as well as, I think there was one boyfriend who responded as well. And then we had about a third multidisciplinary healthcare providers. And we advertised this over social media primarily. We had a brief video with youth and parents that was co-developed with our patient partners, and really asked very broadly, what priorities, concerns, or questions would you like answered by research about chronic pain in children? What happened after that step is, as a team, as a project team, we turn those priorities, those 540 submissions, into research questions that are testable, that can be answered in some capacity by research. We combine them, we remove duplicates, we make sure they're understandable, and all of those kinds of things, and everyone on our project was involved in that. And then we send that back out into an online survey, and this was a smaller group. We sent to 57 Canadians across the country, and they essentially rated how important they thought each of the 112 research questions were. And again, we had about, a third each of patients, family members, and healthcare providers. And from that, we're able to identify the top 25 most important research questions about pediatric chronic pain in Canada. The final step of the process is an in-person workshop, and we held this workshop in Toronto in December of 2018, and 20 Canadians were invited to participate. Again, really representing a diversity that our patient and parent partners on our steering committee and project team identified as important. So thinking about where they come, what province they come from, whether they live rurally or urban, what's their experience accessing chronic pain care, a diversity in terms of race and ethnicity, gender, age, multiple different factors, thinking about the different settings from a healthcare provider. So we had a school psychologist from more an intensive rehab program, and then, other outpatient care. So we really worked hard to have a diversity at that workshop that was really driven a lot by what our patient and parent partners felt was important. I also mentioned we wanted to evaluate, how good were we with our quality of patient engagement, and we used a tool that was developed by Julia Abelson at McMaster in Ontario, called the PPEET, so the Public and Patient Engagement Evaluation Tool. We used one around specifically around the final priority setting workshop itself. But her tool can be used across a number of different engagement activities and be completed by a number of different team members. And it focuses on 4 core principles of quality engagement. So making sure had integrity in our design and process. We're evaluating the influence and impact of the work and engagement we're doing. Whether we're setting a good culture. Lots of things can be barriers to public engagement in health research. In terms including power differentials and all sorts of things. So really making sure we had that participatory, collaborative culture and focus on a common purpose. And this questionnaire that we used around the final workshop itself had 21 statements that you can rate your response to and look at open-ended questions for additional responses. Essentially, I've pulled out some of these here. The scale is 1 to 5, so 5 being high quality engagement for each of these, and 1 would be poor. And so we've just pulled out, and essentially what we did, what participants felt like they had quality experiences. So they felt that the supports were there, that they needed to participate. They felt able to freely express their views, felt confident that our list reflected, the final top 10 list we came up with reflected what mattered most to people with lived experience, that their input would make a difference to our project, and that it will direct the future about chronic pain, future research about chronic pain in children and teens in Canada, and that the engagement initiative was good use of their time. So we had members come from coast to coast, including some representation from Indigenous families and from the North. So I'm going to ask, we're going to show this video. Now's a good time maybe to pause again, but also I think to show the video that shows a bit about the project and then also briefly introduces the final top 10 priorities that were chosen. So I think Paula's going to help us, yeah.
Just need a couple of seconds to load the video and then we're good to go.
No problem. My name is Katie, and I'm a psychologist, and I'm the lead for the Partnering for Pain project. Chronic pain in children is a really significant health issue, and it's really, a lot of research has been done to date and made huge strides over the last 40 years in understanding how pain is assessed and treated in children. But we've really left out one of the most biggest expert voices in this in deciding what research should be done, and that's really of patients and families themselves. I have
I've always thought that there's a gap between research and patients and what they want to see researched and what they understand from research. I was in the beginning really encouraging people that I knew in my community to respond to the survey. So it ended up with 500 plus answers, and now we get to bring this all down to 10 priorities. So it's very exciting to see.
As a parent, I have to say I've felt helpless a lot of times along the way in what I could do to help Catherine. So when we had the opportunity to get involved in this research project, we jumped at the chance, and we've been involved since day one, to come together in a room with, people from rural and urban and different age groups, different dynamics. There's a lot of variation in the voices in that room.
And it's been a fantastic opportunity to come into this project. I always say at many points in my career I am often schooled by patients and families, and that's happened to me today.
Being here has opened up my eyes about what options there are nationally in the rest of the world.
And as a mom of a child who is suffering with chronic pain, it helps me to see there is hope at the end of the tunnel.
Well, I think that this is just the beginning of everything. This is the spark that will ignite a wave of future in the research world.
I just want to say thank you so much for inviting me. I learned a lot, and I learned a lot about people and myself, and I just want to say thank you that you invited me to this wonderful event.
So I'll put up a slide in a second that just lists those top 10 priorities again. But one of the things, there was another research priority setting process that was done in the UK a few years ago for pediatric pain broadly. So not just chronic pain, but pediatric pain and palliative care. And one of the things, as I look at those top 10 priorities, I've pulled out the three from their top 10 that speak to chronic pain. And what I am really struck by in doing this work, so this engagement process, this other priority setting process, was a much smaller group and included one parent on their panel, and didn't do this scope of national engagement and so on that we've done. And what really struck me, I know some of these people and they're amazing in the work that they do, but what really struck me is how the top 10 priorities that came out for them and that came out from our work are framed differently from an entirely different perspective. So the Partnering for Pain top 10 priorities are really framed on the outcome. They're really focused on what is the impact in day-to-day life, what is the outcome of treatment to manage acute pain flares, to what are patients and families looking for improvement in, right? And these top 10 are really focused on specific treatments. So what's the efficacy of gabapentin? What's the efficacy for amitriptyline? And while those are really important questions, it could be that gabapentin's most effective for improving an outcome that patients and families are looking for. And I think the framing of the question really shifts how we think about and conceptualize the work. So I was really struck by these differences. Here are the list of the top 10 priorities again, if you want to snap a screenshot or anything else, but really focusing on prevention, preventing acute pain from becoming chronic in the first place. I think the youth, especially at our final priority setting workshop, hit home about school and the impact of school, and actually 2 of these top 10 priorities address that. Number 2, which is about how does chronic pain impact how I do at school, my academic performance, how far I get in my educational attainment, and what this means for me as I look forward to my future in terms of vocational planning. An emphasis on physical and psychological treatment, a big emphasis on access and delivery, coordination of care, and a desire to reduce disparities in access to care and where that is for chronic pain. A big piece was increasing healthcare providers' knowledge about chronic pain for kids and how it's effectively treated. The most common response in our national survey reflected lived experience of feeling stigmatized, ignored, invalidated by healthcare providers before they actually found someone who identified that they had chronic pain and could access best treatment. So this emphasis on healthcare providers' knowledge, I think, is a big one. Wanting to have strategies that focus on increasing governmental and healthcare organization support for evidence-based care for chronic pain for kids. There's another one about educating school personnel, managing acute pain flares. Many chronic pain conditions have acute pain flares that arise. And so wanting to know more about how can we manage that better. Chronic pain and mental health and how those interact, how are they related, but also how can they be effectively diagnosed and treated. And when are treatments most effective? Is it all at the same time? Is it, at what point is which type of treatment best introduced? And how does this interact with ongoing medical investigation, where families may still have or healthcare providers may still have a lot of questions about what's actually going on? Some of our challenges for people interested in this work were conversations about, is patient partnership, is work like this considered research? Are members of our research team research participants, and doing some education with our research ethics boards to say, no, these are equal members of our team and should be treated as such. The need for greater diversity. I think every time I speak with people who do patient partnership and patient engagement work, how we support greater diversity and greater capacity for people to partner in this type of work. And also that there's variability. We had people who were interested in partnering when we applied for the grant, who then when we were funded were no longer interested. People, for a variety of reasons, or people who joined midway through and other things. So I think the need to be flexible around that. And we really worked hard to have meaningful engagement virtually. Our project, I didn't know everyone in person when we started partnering together. And so really trying to create those meaningful relationships from one end of the country to the other. In terms of practical feedback from our priority setting workshop, patients and families wanted more time for discussion and wanted to receive some more information earlier. We did it over one day, and there was reflection that was too long and that we needed to split it up over 2 shorter days. No surprise, we needed more comfortable chairs. I think that's true in many hospitals and research and healthcare settings, and that people wanted more inclusion of fathers and other clinicians that weren't part of that group, for example, social workers. So I'll let Catherine talk more about this as we move forward, but we've really focused our knowledge mobilization activities on generating awareness and interest, including at a lobby day with Skip on Parliament Hill in Ottawa with 2 other patient partners from our project there, Adam and Justina, creating open dialogue with researchers and people with lived experience at scientific meetings. So you can see presenting there with a number of patient partners who were able to join at the Canadian Pain Society meeting, and then also another engagement meeting, and we're working to facilitate adoption of these priorities. So for those of you who are familiar, there's a federal Canadian Pain Task Force from the Government of Canada, and we felt very privileged, actually, that in their first report, which came out last June, that the Partnering for Pain project was mentioned and included. So we know that the priorities we've identifying are playing a role and are on the in the view, I guess, of those who are working to direct the future of chronic pain care for all Canadians.
Awesome,
so with
Katie.
That, yeah, go for it. No, I was going to say with it, I'll turn it over to you, Catherine.
All right, sounds good. So first, I'm just going to start off talking about the things that went into making this such a positive experience as a patient partner. So as Katie said, we were a cross-Canada team, and we had a combination of in-person and online interactions. We mainly used online tools like Basecamp and Zoom to discuss a lot of our activities. But we also got to share our project together at a number of conferences and had obviously the final priority setting in person in Toronto. So online was really used as a great tool, especially for someone with pain, because I could do a lot on my own time. And when we did schedule Zoom meetings, Katie was absolutely amazing at making sure everyone could attend. My mom was also a part of this project, which you might have noticed on the video, and she works full-time, 9 to 5, and Katie absolutely made sure she could make it. So the flexibility of online was great. And having the meetings after work hours or around whoever is involved in the project. So sort of working together in terms of scheduling. Another huge asset was how Katie structured it. She was the main point of contact for all the patient and family partners, which made things very organized and clear. I think it also contributed to an open and less intimidating dialogue. Although there were many researchers affiliated with the project, we weren't thrown into it alone as the only patient partner with 10 researchers at the table. Our project was definitely very different. We had many patient and family partners on our team, and we also had the opportunity to build a relationship with Katie as the main contact. Another thing that was great were the ways in which patient and family partners were recognized in this project. So compensation, we were paid $40 an hour for our time, and also conference and travel expenses were covered. And on top of the compensation component, we are also listed as co-authors on the publication. And for me, that meant the world because I never believed I would have that opportunity in my undergrad. So I really thought that that was a great recognition, and I really appreciated that. So this project gave me many opportunities to learn, and it was sorry about that. It has really sparked my interest in research and has made me feel like I can contribute to this amazing field. Having the lived experience with pain was valued rather than treated as a burden, which can sometimes be the case when you're in work conditions. So that sums up everything that went into making the project a positive experience for me. I think we have some quotes from other patient and family partners, which you can read through, just so that you get a sense that their experience, I think, was very similar to mine and had a really great experience on this project. So on top of that, I wanted to go into, I think, the benefits of having patient and family partners to the project. As Katie said, there's not a whole lot of research on evaluating the benefits, but we know sort of generally the benefits of having patient and family engagement and research. So for our project, I just wanted to highlight the ways in which I think it was beneficial. And I actually used our project as an example at a research services presentation that I did. Someone raised their hand and said, I know patient engagement and research is obviously a great thing, but can you give me an example of it directly impacting the study and the study findings? So funny enough, I think our project is a perfect example. I can't help but think how different the top 10 list would be if it had just been solely researchers narrowing down the responses of the survey. And even before getting to that step, I believe involving the patient and family partners throughout the process dramatically impacted the project. For example, when we developed the survey, all of the partners contributed to the language so that it could be best understood by the respondents. The survey was also promoted by all the partners, including the patient and family partners. This allowed it to reach our individual communities. For example, I reached out to the Ronald McDonald House here in Halifax since I volunteered with them in the past, and they were able to advertise the survey at the house here in Halifax. Finally, don't be afraid to call on patient partners to help you share the project at meetings and conferences. I think having patient partners present and co-present the project is particularly powerful and can help the project stand out. The Pediatric Pain Letter actually noticed our project from a presentation I did at the International Forum on Pediatric Pain, which led to them publishing our piece, a piece on our project. And then also on a side note, these opportunities of presenting are also great for the patient and family partners. For me, Dr. Christine Chambers actually reached out for me to be a part of SKIP after seeing me at the Canadian Pain Society. And I'm now the patient engagement coordinator for Solution for Kids in Pain, SKIP. And Katie's the assistant scientific director. So it's actually kind of funny how things came around full circle. So that kind of concludes my take on patient engagement. And I just really encourage everyone to incorporate it into their projects.
Thanks so much, Catherine. So I think, Catherine's been able to share some of her experience there, and we're certainly looking forward to discussion and questions around this. But I just want to leave all of you, I see there were, 90 people, 90 different kind of logins for this talk. And I really see this work as a call to action. We've listened to what patients and families and frontline clinicians think are important in terms of how we improve the lives of youth living with chronic pain in Canada. And I think really the onus is on all of us now to act and to listen and to work together in a collaborative way to address these top 10 priorities as we move forward. And just to pull on something that Catherine mentioned, which has been an incredible learning for me as a researcher and a healthcare provider. We obviously do the work because you want it to have impact and you want it to benefit the people who are living with chronic pain. But Catherine's comment, and in addition to a number of our other patient and parent partners, the greatest voices that are listened to in all of the dissemination and knowledge mobilization activities that we've done, it's no surprise, but it is the people with lived experience who are the greatest champions and the greatest disseminators for the findings that they've been integrally involved in identifying as priorities. So I think as much as I can encourage my colleagues and continue to practice to support those voices, to partner with those voices and to put them ahead and at the forefront as leaders, I think is where real improvement and change for pediatric chronic pain is going to happen. So there's a photo from our final top 10 priority setting workshop group and just the names of all the project partners and researchers and clinicians from the various institutions across Canada that have been really involved on our project team. And feel free to contact me if you've got a question for Catherine too. I'm happy to pass it on afterwards, but also happy to take any questions now.
Thank you, Katie. There's a few comments and a couple of questions, so I'll start with the comments. There's a few comments acknowledging that people living with chronic pain can actually have difficulty in participating in projects like this, and wondered about if you only connect with the people who respond and not those who are unable to respond, what sort of risk does that have for not getting all the barriers and facilitators and the perspectives of those who cannot participate, who might be most affected by this?
Katie, can I jump in really quick?
Sure.
For you answer this one?
Of course, I was going to suggest you go first. Yeah.
So yeah, I just wanted to say, obviously you see a dramatic difference in people's functioning with chronic pain. But really in terms of flexibility of the project, I think there are so many things that you can do for your project in order to make it more reasonable for patients to be involved. Obviously, there's still the chance that you're going to miss some people, but I do think there's a great opportunity with online resources, with scheduling, with all the things that I sort of mentioned before with our project, that you can include a lot of voices if you make it a priority.
Thank you.
Yeah, thanks, Catherine. I just add to that. I mean, there were times when that came up throughout our project. We had a youth partner on the project who decided that, where she didn't want to focus on her pain as much by engaging and partnering in a project like this, and wanted to put her efforts elsewhere, and chose to kind of move on to other things and not stay as engaged. And then, we had someone else, so I think the key is flexibility, and whether that's when meetings are held, whether that's opportunity to be as engaged as you want. Catherine was obviously very engaged, but we had other patient partners who were less engaged as it fit kind of their needs and their lifestyle and their pain. And in terms of the final priority setting workshop, we worked really hard. We had invited a youth who was unable to attend because of a significant pain flare. And so we had a conversation over the phone to say, what do you think about these top 25? What's important from your perspective at engaging, in terms of these top 10 priorities? And even though he wasn't able to be there for the day itself, there was an opportunity to contribute. And, actually the top 10 that did land very much aligned with what he had felt was really important and would have wanted to share. And we did that at the meeting too. There was someone else at the meeting who felt a bit less comfortable speaking up in the group. So we had conversations more individually throughout the day to bring that back to the group itself. So I, to echo Catherine's kind of eloquent words, I think flexibility is the key. I think you have to be open to that. And I think sometimes that's new for researchers. I think that's new for healthcare providers. And I think it's new for the institutions within which we work. There are a lot of systemic challenges that need to be addressed. And we as researchers and healthcare providers within this system have a role to play to advocate to make those barriers less cumbersome. So whether that relates to compensation, so for example, being able to, or covering expenses, so being able to pay upfront before someone participates, if we're able to do that. We're not always, but even just being able to compensate sometimes is a space where, that's new for institutions to think about. So I think we have being flexible and being advocates to increase that flexibility as much as possible.
Thank you, Katie and Catherine. Another question here is, where can I find resources currently available to help manage pediatric chronic pain? I'm an RN at Alberta Children's Hospital, and we frequently encounter these patients on our acute care unit. I would love to be able to be of more help to them.
Awesome.
Great question. And if we know each other and you're at Alberta Children's, send me an email. And if we don't, send me an email. I'd love to chat more too. And there's certainly a number of exceptional resources for youth and families themselves. Maybe I'll suggest a few, Catherine, and then you could, if you've got any you want to add. Certainly, there's an organization called Pain Bites, BYTES, in Australia that has some wonderful videos for healthcare providers and for youth about chronic pain. I know that Children's Healthcare Canada has a pain toolkit And there is one for chronic pain as well that's on the Children's Healthcare Canada website that we're working within SCIP to update and to make a bit more accessible. But there's a phenomenal amount of resources there that some of our colleagues in Canada have done incredible work to pull together. So I'd also suggest looking there. And the Comfortability is a great online resource for families. It's a one-day pain management workshop. We run it at Alberta Children's, and also there are a number of other hospitals in Canada that run it, but they also have a website, so it's thecomfortability.com with some resources on it. And that program was developed by a psychologist, Rachel Coakley, at Boston Children's Hospital. And if you're interested to have a further discussion, we and our healthcare provider, we have an ongoing Ask Me Anything through a partnership with SCIP called The Rounds right now that you're welcome to engage in. And both myself and Dr. Alan Finley, he's a pediatric anesthesiologist at the IWK, are on there all this week, kind of answering all questions kind of related to pediatric pain. Those are a few that come to mind. There's lots of others, books for families and other websites and stuff I often recommend, but a few off the top of my head. What would you add, Catherine?
Honestly, I would just add that I share your sentiment. I think there's a lot of resources out there, but sometimes they can be quite difficult to find, and knowing which ones are appropriate and which ones aren't. And that's sort of where SCIP is hoping to come in and disseminate that knowledge appropriately, so that it gets into the right hands of people that can really use that information. So yeah, thank you for your question.
Yeah, beautifully said. Yeah, certainly it's an activity we're doing with SCIP. Yeah.
There's a couple of comments around stigma. One has to do with stereotyping, and in this case, it's a adolescent or a teenager, and what to do when healthcare providers are not believing the pain and attributing it to something else like growth hormones or depression without trying to get to the root causes of pain. And that's this sort of stigma and stereotyping reinforce barriers that parents and some healthcare providers and patients themselves are experiencing. What, if anything, any comment do you have around the stigmatization of pain and how this project and others might help address it?
Yeah, good question. I think, unfortunately, experiencing stigma around pain itself is still a common enough experience. And particularly with youth I meet, youth I engage with, and families I talk to, I think a lot of that comes from healthcare providers, but also comes from others in the youth lives. So from teachers is another, or educators in the school setting is another experience I often hear about, and then potentially from friends or from family members as well. So I think it is a challenge of pain because of the invisibility of it, and that it's harder to see, coupled with, that mental health symptoms can be a natural consequence of living with pain, or may have been existing beforehand. And so I think that can lead to quick judgments sometimes by others in terms of what's contributing to pain itself. I think, I think one of the things we're trying to do with SCIP, or we are doing with SCIP, is really to create more public awareness about pain itself and generate more discussion and conversation, and doing that in as many ways possible that we can. So whether that's integrated through, provincial pain strategies and the Canadian Pain Task Force and other activities like that, as well as through sharing knowledge that's really targeted towards healthcare providers. Healthcare providers get reasonably little education about pain, period, let alone pain in kids, let alone chronic pain in kids. So it's an area where there's an incredible knowledge gap from the amount that we know from a scientific standpoint about it. I think there are some great organizations that are also working to do that actively and create that education more accessible for healthcare providers. There's an interprofessional pain curriculum hosted through Sick Kids that really touches on that. And Pain BC as an organization has some wonderful resources there as well. But I think it's a challenge, and I would love to say there's an easy answer, but I think being able to, if it's you that's experiencing it, certainly trying to connect, if possible, with a care provider that has some more experience or expertise related to chronic pain in children. And there are some, not all just in kind of urban centers, but there are some throughout, as well as kind of finding some resources yourself and that we some of which we've talked about, to work to kind of empower yourself with some of that knowledge. I think a lot of education, real understanding about chronic pain can be very powerful for kind of changing how you cope. There's more to say, but we'll leave it there for a moment. Catherine, would you like to add?
No, really just the education component. I really hope with this project and with SKIP and all the great work that Children's Healthcare Canada also does will contribute to healthcare providers' knowledge, and even patients' knowledge, knowing what's going on with them and trying to advocate for themselves to get a diagnosis. I know for me, it took me a while just because I didn't have the diagnosis of chronic pain. I didn't know what was going on with me. So it was definitely attributed to a lot of other things, whether it was mental health at the time, being an adolescent and just not wanting to go to school, things like that. So I think basically training in pain and having more people have knowledge on pain will contribute to hopefully decreasing the stigma. When people are educated on the topic, they won't have sort of these wrong notions about chronic pain.
Thank you both.
Yeah, and I think this is,
Go ahead.
I'll just add one more thing, Paula, if that's okay. Just,
Sure.
I think hopefully there are moves that are happening. So, the primary diagnosis of chronic pain is reasonably new. So the World Health Organization has international classifications of disease, and it's on the 11th edition. And for the first time at the end of 2018, early 2019, chronic pain as a primary diagnosis was included in the ICD-11. And so, conversations I've had even with school teachers, around how does that change what it means for a youth to be able to get supports at school when there's a diagnostic code that can go with that, changes the supports and things they're able to offer. And I think provides another, for lack of a more eloquent way to say it, kind of stamp, just as Catherine was talking about, getting a diagnosis. I think the availability of that, which is recent, can hopefully change some of that as well.
Wonderful, thank you. And the very last comment is actually a solicitation of advice from the Journal of Adolescence that's interested in soliciting a review on the effects of chronic pain and other chronic medical conditions in youth, and they're looking at it from a developmental perspective. And the question is, what would be a useful approach to soliciting such a review?
Oh, so this is someone from the journal who's looking to solicit a review in the area.
Yes.
Send us an email. Would be happy to connect about that. I think we have a lot of ongoing work and upcoming activities within SKIP that are certainly looking to address that knowledge gap, and some of which do require reviews and other scoping looks at literature around that. And we also have a number of colleagues in that area that certainly taking that developmental approach, how pain changes or looks different throughout child development from birth through to later adolescence and into adulthood. There's lots of incredible work going on in that area and lots of evolving knowledge. So yeah, absolutely happy to continue that conversation.
Wonderful, thanks. So that's the end of the questions. Any last comments, Catherine and Katie?
No, just thank you so much for everyone that took time out of their day to join in. We are very excited to share with you all.
And I just would add thanks to Children's Healthcare Canada and the support to co-present together. It's a real pleasure to have the opportunity to co-present with a youth partner and patient partner on our project and to share this work.
Yes,
Wonderful.
thank you.
Thank you. And there was a couple of comments about how to get a link to the video and how to share the slides. And we'll with your permission, we would post them on the Knowledge Exchange Network, and people would get a notification when that is posted.
Absolutely. They're also welcome, Paula, to look at our website. So Partnering for Pain has a website, www.partneringforpain.com. And you can read more about the project, the top 10 priorities, and the videos embedded in there as well. So it's another great place to look at resources. We have a one-pager to download, links to publications, all sorts of stuff.
Wonderful. I'll include that link as well. And thank you so much, Katie and Catherine. That brings us to the end of this webinar. Children's Healthcare Canada hosts our Spark Live webinars every Wednesday at 11 a.m. Eastern Time. It's always great if you can watch live, as your questions and comments really enrich the discussion. But if you can't watch live, the recordings of these sessions are made available after the fact on the CAN. Next week, on February 5th, we will have an interesting presentation from the Canadian Foundation for Healthcare Improvement, working together to improve access to care, the Priority Health Challenge. And during that session, we'll learn about teams across Canada that are participating in that challenge and working to improve patient and client care and outcomes. The challenge offers an opportunity to learn and connect with peers, share your team's work, raise your organizational profile, and have a chance to win up to $400,000 available that you can use as you choose. The Challenges program team at CFHI will be sharing more about this opportunity and highlighting the work of current teams working to improve access for children and youth seeking mental health and addiction services and home and community care across Canada. If you have not already done so, please sign up for our Children's Healthcare Canada Spark newsletter to stay up to date on all our activities and events. So thank you again for joining us today. Thanks to Skip for supporting our webinar program, and hopefully we'll see many of you back here next week. Bye, everyone.